Good day, everybody. I'm Dr. Suresh Naidu. I'm going to give a talk on field disaster response as a part of pre-hospital care. In 1993, a tragedy shook our nation. We in Malaysia are well accustomed to blissful and peaceful life. Our nation is relatively disaster-free, but on 11 December 1993, it woke up to a tragedy. On that day, a tower in suburban area in Ulu Klang known as Highland Tower collapsed. This tragedy leads to improvement of disaster management in Malaysia. As an outcome of this tragedy, Malaysia placed disaster management under National Security Act. Under Directive 20, or also known as Harahan 20 in Malay language, disaster management was placed under National Security Council. Disaster was defined in the Directive 20 as an event that occurred suddenly, complex in nature, loss of life, destruction of property and/or environment, disruption of community daily activities, and it is divided into three main levels of categories depending on the management capability and capacity. In 2015, National Disaster Management Agency was created to take over the management of disaster from National Security Council. Civil Defence, or also known as Angkatan Pertahanan Awam, acts as a secretariat for NADMA, and these units are placed under Prime Minister's Department. Depending on the scale of disaster, disaster management are tiered according to the three levels. At the lowest level, a localized incident and no probability to spread is managed by authorities at the district level. An incident involving two or more districts but no potential to spread will be coordinated by the state with the districts. At the highest level, a complex disaster covering a wide area or more than two states which require greater financial and human resources are coordinated by the central government. This is disaster management level 3. A major incident site management depends on the severity of conditions, on the resources available, geographical location, and political situation. Mass casualty incident is disaster in which patient care resources are overextended but not overwhelmed. Focus is on most life-threatening injuries. Mass casualty events are defined as disaster in which patient care resources are overwhelmed and cannot be immediately supplemented. Focus is on identifying those patients with greatest possibility of survival. This may not be even level 1 disaster activation according to NADMA. But however, this is a disaster for pre-hospital care service or emergency department and sometimes involve hospital activation for disaster response. The principle of disaster management is to do the greatest good to the greatest number. Let's go through what should happen in ideal field disaster response. We may summarize it as 5S. Scene size up, send info, set up, start, and stand down. The role of on-scene medical commander should be ideally delegated before the team leave for the scene. On-scene medical commander or someone superior may delegate the subsequent task according to the resources. There may be liaison officer, triage officer, treatment officer, traffic officer, and scribe. When the resources are limited, maybe some of the officers may be playing more than one role. As in any pre-hospital care response, we will have to do scene size up. Same as any other responding at the scene, we will start the scene size up right before getting off the ambulance. Safety, situation, and environment. Let's go through what we should do during scene size up. The first and most important is safety, of course, because we don't want to become victim ourselves. We survey the area involved. We look for the apparent number of victims, type of the incidents, whether it's an industrial accident, natural disaster, or a landslide, or a road traffic accident, and so on. We look for the scene assessment, whether it is according to the to decide where to set up the medical base and so on. We look for the severity of the injury. Sometimes all the victims will be mostly green, so we may not need to pool too many resources. At the same time, we try to identify on-scene commander and the command post if it's already set up. We also look if any other agencies already arrived at scene. As part of scene survey, the on-scene medical commander should identify on-scene commander. Normally, on-scene commander is police, who is in charge overall of disaster site. In their absence, forward field commander, which is a firefighter bomber, will play the role. On-scene medical commander will report himself to the on-scene commander, whoever in charge of disaster site, and gather incident information, and from time to time provide situational reports to the base. He will establish initial medical control points and establish liaison with other emergency services. After scene size up, we start send info to the base. Basically, it is everything that matters during the scene size up we have to inform to the base. Casualties numbers and type of injuries, the hazards, the access to the location, the actual exact location, the emergency services which are available at scene or any more emergency services which are needed, the type of incident and the safety. Next will be to set up medical base. The location of medical base should be discussed together with on-scene commander. It should be ideally in a safe location in yellow zone in a disaster area and should have easy ambulance access to pick up patient and dispatch to its destination. This is an ideal disaster zoning area. At the center, there will be red zone, which is a ground zero and operational area for specialized rescue team with special expertise. Outside it will be yellow zone, which is a placement of on-site command post which will coordinate all these other agencies with their bases, including fire and rescue department, emergency medical services, and civil defense, smart team, and so on. At the green zone, there will be placement for media management, victim family center, counseling center, food and supplies, mortuary, rest area, etc. This zoning is not static. A fire in the red zone area may blow and may change the yellow zone area to red, or smoke may change the yellow and green area to the red area. So none of this zoning is static. The red zone area, which is the inner zone, is high risk zone. Normally, it's approximately 50 to 100 meters. As mentioned earlier, for rescue workers, marshal and fire unit, rapid response medical team may enter with permission of the on-scene commander. The yellow zone, the middle ring, is supporting team. It's a base station for medical, police, and fire. It's a sorting out the injured and command center for all the agencies. And then there is green zone, which is the safe area. Press, temporary mortuary, and transportation area will be located here. And as I mentioned earlier, none of these zones are static. It can change according to the evolution of disaster. Let's don't confuse zoning in the medical base from the disaster zoning. In medical base, we will triage according to red and yellow for the victims of the disaster. The green zone patients would have been evacuated from the scene as soon as possible after taking their particulars. So zoning in medical base is different from zoning in disaster area.
Then once the medical base is set, or even if the medical base is being set, we will start triaging the patient. There are two types of triaging system. One is start triage, another one is assault triage. Start stands for simple triage and rapid treatment. And as for now, this is the most common triaging system done in field disaster response in Malaysia. This is how start triage works. The walking wounded are deemed as green, and those who are walking will be led away, will ask to follow triage officer or on-scene medical commander away from the disaster area to the area which is safe for them or where they can be transported from the scene, either to the hospital or to the nearest any other healthcare facilities available. So the walking wounded will be leave the scene. They may or may not be taken to the medical base, but they are not transported with hospital with ambulance. Next, we go to assessment of respiration. Those who are not breathing will be we position the airway. When we position the airway, if patient is breathing, we consider that as tag rate immediate. And of course, don't forget to place airway adjuncts for these patients. Those who are not breathing when airway is repositioned are considered deceased. Next, we go to those who are already breathing spontaneously. Those who are breathing more than 30 times per minute respiratory rate will be deemed rate. They'll be not assessed any further. Just as this, you already place airway adjunct, they're breathing now, and they are not assessed any further. Tag rate, tag rate. And those who are respiratory rate less than 30, we look for perfusion. If perfusion, we may feel for radial pulse present or absent or capillary filling time. If radial pulse present, we assess for the mental status. If radial pulse absent, we tag immediate. At the same time, if there is any bleeding, we try to control the bleeder. If we are not sure about radial pulse, we may do capillary refill. More than 2 seconds, tag rate, control bleeding. Less than 2 seconds, or radial pulse present, assess mental status. Then in mental status, if cannot follow simple command, red. Can follow simple command, delayed, yellow. So as you can see here, position away, if not breathing, position away breathing, tag red. No further assessment. And respirate, if a patient is breathing more than 30 per minute, tag red, no further assessment. If less than 30, assess perfusion. If perfusion is good, go to assess mental status. Perfusion is bad, tag red. If a mental status is good, yellow. Mental status is bad, red. So that is a start triage. Okay, jump triage is type of triage done in pediatric age group below 8 years old. If patient able to walk, we lead them away from the scene and we do secondary triage. If patient not able to walk but not breathing, we position away. On positioning away, if patient is breathing, we tag rate. If patient is not breathing after uh, positioning the airway, we check pulse. If pulse is absent, we declare them deceased and tag black. If patient have pulse but not breathing, we give 5 rescue breath. And the rescue breaths, after rescue breath, patient is still apneic, deceased, tag black. If patient is breathing after 5 rescue breaths, we tag red. If the patient is breathing spontaneously, we look for respiratory rate. Less than 15 or more than 45, tag rate. Between 15 to 45, look for palpable pulse. If no palpable pulse, tag rate and do necessary intervention. If got palpable pulse, assess AVPU. If it's appropriate, tag delayed. If it's inappropriate, tag immediate. Another type of triaging system which is being increasingly used lately is SALT triage. SALT stands for sort, assess, and life-threatening intervention and transport. SALT triage makes more sense and more rational to be used in disaster situation. You will assess according to the ability to walk, wave, or lay, or unable to do both. Step one, you do global sorting. Those who can walk will they will be following one of our paramedics away from the scene to somewhere where they can be assessed last or transported to the hospital. Those who can wave and do purposeful movement will be assessed second. Those who are still or with obvious life-threatening injury will be assessed first. The step two will go for individual assessment where the still patient will be assessed first, followed by the wave and last the walking wounded. The life-threatening intervention which we can do at the scene is first is control major hemorrhage, airway if patient is not breathing. If patient is not breathing, we will be deemed them dead. But if child, we may give to rescue breath. And we may do chest decompression such as needle thoracocentesis, or if open sucking chest wound, we may do three-way seal and so on, or auto-injector antidotes in special situation. And if patient is breathing, we look for whether patient obey commands or makes purposeful movement, has peripheral pulse, not in major respiratory distress, and major hemorrhage is controlled. If no to any of these questions, we look whether patient is likely to survive for the given current resources. If no, we consider them expected. That means patient likely to die. If yes to if he is likely to survive with current resources, tag him rape. And if yes to all of these questions, obey commands, makes purposeful movements, has peripheral pulses, not in respiratory distress, and major hemorrhage is controlled. If yes to all, with minor injuries, we deem them minimal. If not minor injuries, we consider them delayed. The last in field disaster response is to stand down. Before standing down, account for every victim, account for every staff, and stand down only after discussion with on-scene commander. With this, thank you very much. See you in pre-hospital care course. Thank you.